to introduce our next group of speakers and presenters today from Legacy Health. We have Sue, Deborah, Kristen, and Van here today, here to teach you about stethoscopes. We will be learning about those. And then also learning about, as I mentioned earlier, kind of what is a simulation team, what do they do, and they'll be running through that with you all as well. So Legacy Health Simulation Team, take it away.
All right. Well, thank you, everybody. We really appreciate you joining us today for a brief discussion about the value of a stethoscope. As you learn, my name's Kristen. I'm joined by my wonderful colleagues, Sue and Van, which will show you a little simulation here after this brief presentation. We are part of the simulation specialist, as you just learned, for Legacy Health. So a very unique, very specialized component of nursing. So what is a stethoscope? A stethoscope is an invaluable tool that we use as clinicians to hear, or we use the word auscultate, which is a Latin word for active listening, to body sounds. It's practically a part of our uniform, I would say, and it's used every single day as part of our physical exam. The genius of the stethoscope is really in its simplicity. It looks somewhat complex, and it started very simple. And it's really an instrument, as I said, to listen to the various internal organs, and it provides us with an assessment on how well they're working, or maybe not working so well. These different sounds then help us diagnose what the problem could be. Today, stethoscopes consist of three main parts. There's a chest piece, which is the circle part here of your stethoscope. And this part has like a little membrane on it that senses vibrations of sounds inside the body. And those vibrations then travel through the long tube that you have here. And that sound then is transmitted up to some earpieces. And these earpieces then, when placed into the ears properly, amplify that sound. And then we get a glimpse into what's going on inside of the body. The stethoscope that we use today that you may have in your hands looks a lot different than the initial stethoscope. The one over here that you're seeing, this actually, I will tell you, actually before the 1800s, clinicians used to literally just put their ear next to someone's chest or abdomen and hope that they could hear something. Not real effective. And in 1816, there was a provider in Paris, France, who was a little uncomfortable lifting up a woman's gown to listen to her heart. So he developed, as I said, very simplistic, a wooden tube with a little earpiece. And he then could listen through this wooden tube, which gave him a little separation, if you will, from this intimate interaction. In 1851, the stethoscope evolved a little bit. It became no longer wooden. They used more of a flexible rubber, if you will. And they created two earpieces so that you didn't hear other noise from one ear that could have mistaken from what you were hearing within the body. But it still was quite heavy and it was short, so your distance from the patient was very close still. However, it took another 100 years till this stethoscope got another update. And that's more common like the one that you're seeing right now. This was developed in like the 1960s by a gentleman named Dr. Littman, and a lot of stethoscopes out there, the brand Littman is very common. He developed this. It's lighter, it's longer, it has better acoustics, and that's what most nurses use currently. However, things are really evolving. The future of the stethoscope has completely changed actually the landscape of the physical exam. Now, there are stethoscopes that use artificial intelligence to detect the sounds and the electrical signals, and it converts these signals into your smartphone. And it actually gives you a picture of what you're hearing from sound, or if it's the heart they're listening to, we can see the electrical activity of the heart. And then that can be reviewed with the patient, with other providers. It can be shared in the electronic health record. So it's come quite a ways, if you will, from a hollow wooden tube to what you have in your hands today. As I mentioned a few moments ago, the stethoscope is a tool to listen to sounds within the body. And what you hear is really dependent on how well you use it. So the ear tips, you should have some silver hooks here with white little tips. I don't know if you can really see because we were challenged with how we wanted to describe this to you. The ear tips are deliberately pointed in one direction. You can see the difference here. We want these ear tips pointing this way to my nose. So if you kind of go to your chin, you want to have these coming up to your nose. That's how you know you have it in the right direction. So they should go into my ears, and I might need to twist a little to get a little seal. If I've done that correctly, the sounds in the room become faint. And then all I hear is whatever's vibrating through the chest piece and the tubing. But you have to be real careful, because anytime you touch the chest piece or parts of the tubing, you're going to hear different sounds, and that may be confusing, right, in your assessment. So when we go forth to hold it, there is also a specific way, and that is looking at the picture that's over here. We want you to hold it between your index finger and your middle finger, forming a V. And you're going to hold the chest piece that way when you're putting it onto someone's body. I know you can't see that right now, but we'll put a mannequin here for you in a moment, and we're going to show you where you place it exactly. Thirdly, I should say, as I put it over my shirt here, we really want to avoid placing the stethoscope over thick or layered clothing, as that can produce these rustling noises, and again, can lead to confusion in assessment or diagnosing of what's going on. It's also really important to keep your stethoscope clean. You need to clean it before and after every single use to mitigate infection from one patient to another. And we need to keep it clean to maintain its functionality. Alcohol swabs are a real common thing you'll see nurses and doctors use. They'll clean the chest piece with an alcohol swab. They'll clean the ear pieces with an alcohol swab. It's real important to keep lint and dirt away from the chest piece and the ear pieces, because they can obstruct the sound and you won't hear appropriately. It's important to keep your stethoscope away from extreme heat or cold or liquids, like you don't want to dunk it in anything, because that can really damage the tubing here. It can cause cracking. Once again, that's going to obscure the sound traveling to your ears, and you won't be able to hear it correctly. So who uses a stethoscope? Well, a whole hell of a lot of healthcare workers do. We got physicians, we've got nurses, we've got certified nursing assistants, we've got nurse practitioners, we've got medical assistants, even veterinarians. They all use a stethoscope as part of their physical exam. These assessments, whether they occur in a hospital room, in a doctor's office, or a clinic, maybe a school nurse, you went to go see the school nurse in your school. All of them, maybe it's a home visit. You've had someone come to do wound care or do diabetic checks. All of these places, it would not be a complete assessment without the valuable information that the stethoscope provides. So why would we use this stethoscope? Well, they're used for various assessments. The most common is to measure blood pressure. And I know today you can go to a grocery store and stick your arm in an automatic blood pressure cuff, but those are not very accurate. In order to get a true accurate blood pressure, you really should use a cuff that gets squeezed up on the upper arm and use your stethoscope to listen to the different sounds. It's also used to identify blood flow through the heart. We can listen to air movement going in and out of the lungs. And we can also listen to your belly, to the intestinal motility, and we can detect if there's an obstruction, nothing's moving through. So these are key elements for the physical exam. When we listen to a blood pressure, I'm actually going to pause this for just a moment before I won't start that video yet. There's two numbers that make up a blood pressure. And when you inflate a cuff around the upper part of your arm, I'm going to guess that all of you have probably had a physical at one point in your life and have had your blood pressure checked. And you know when they blow up that cuff, it's really tight. And they'll put their stethoscope in their ears. And the first sound that they're listening to is reflective of your systolic blood pressure. That's the pressure in the vessel when the heart is squeezing or contracting and ejecting blood out to the body. That's the first number you hear in a blood pressure number, or the top number. The second sound you hear is reflective of diastolic pressure. That's when the heart is actually at rest and it's filling with blood. That's the second number in your blood pressure reading. Now I'm going to show you a little video clip, and this is someone actually blowing up a blood pressure cuff with a stethoscope in their ears, and you're going to hear the sounds that you would normally hear through a stethoscope. I want to see if you can pick out the first sound and the second sound. So it's when the sound comes on and when the sound actually goes away. You're going to be able to hear them pretty closely, and I want you to look at the numbers here on this sphygmomanometer. I'm going to hit play. This is just blowing up the cuff right now. So you're listening. When do I first hear the sound? And then you're listening for when does it go away? All right. It's 138/80, and that's exactly what we're listening to when we're checking someone's blood pressure. A normal blood pressure should be about 120/80. So we'd get concerned if that number actually is above 140. Oftentimes they start medications for patients. So that's really important for us to be able to make that assessment and give that number to our healthcare team. So that's kind of our brief presentation to you to let you know the value of using a stethoscope, how we may use that in our profession as nurses or healthcare providers. I'm going to hand it over to the rest of our sim team here, and we're going to do a little bit of mock-up to show you some of the equipment we use and some of the brief trainings that we might do with staff.
So Sue will go over some equipment that we use in simulation and education.
So in simulation, it's all about training and meeting the needs of our learners. So if we have newer nurses, they may need to practice some basic skills. So for instance, we have IV arms that we can hook up to blood, fake blood, and then they can practice inserting their IV needles, and then they get a blood flush back like they would in a real person. But this is just an arm. Now we have a high fidelity mannequin here that has the exact same setup. And so in this instance, it's part of an entire body, but we do have just certain parts. Another example is we have a lot of patients that require long-term therapy, medication therapy. So we have specialized lines that are put into them for their comfort, to reduce the risk of infection, those types of things. And so this type of trainer allows us to let them practice dressing changes, assessing at the site to ensure that there's no infection going on. So it's just a different type of trainer. Another low fidelity type task trainer essentially is the CPR mannequin. And hopefully many of you have already taken a CPR class. When we take ours out to our staff to help them practice those types of skills, we have what we call a feedback device. And so we're going to show you what that looks like. So when our staff practices, you're going to see this feedback device, and it's going to tell them how they're doing so that if they're doing something not right, they can self-correct. So we measure rate, depth, and recoil. So Van's going to let us know here how I'm doing.
Sue, you're doing great. Your rate is good. Oh, you're going a little fast. Let's slow it down a little bit. And 1 and 2 and 3 and 4. There you go. Now you corrected. That's great. That's so good self-correction. Oh, let's see. Now you're not deep enough. Let's see if we can go a little bit deeper. Let's try that again. Yes, there you go. Now you're back to green. Perfect self-correction. Now look like the recoil is not coming back. So let the chest kind of rise completely. There you go. Now you're back. Your recoil is doing great. So those are the three important things: the rate, the depth, and the recoil.
So that's what allows us to ensure that our staff are practicing high quality BLS or basic life support, CPR, so that when we're not wasting practice time. We always want to know that what we're doing is a benefit. So we're going to show you our code card over here. Sorry, I went a little out of order. Poor Van, she's just rolling with it over here. So this is our training code card, which looks exactly like our real code cards. Because the importance of, in an emergency, the staff needs to be familiar with the equipment that they're using. So in this case, Van will open a couple drawers for us. We have a medication drawer. This whole drawer is just full of medications that are used during a code, what we call a code blue. So we have courses that we take to get certified in, like advanced cardiac life support. So this drawer doesn't have every single med that may be needed, but it is going to allow us to give medicines in an emergency. Our airway drawer is going to have a barrier device that allows us to bag our patients and manage airway. We have intubation supplies in there. And just like the nasal cannula, which is just the plastic prongs, and then we hook things up to oxygen here. So when we might use this is in this case. So say I walk in to check on Mr. Jones. So Mr. Jones, oh my God, I need some help in here. Dan, I need you to call 911 and grab the code card.
I'm going to grab the code card and call 911.
There's no pulse. I'm starting compressions.
I've got the code card. I called 911.
Apply pad to the patient's bare chest. Plug in pad connector.
I'm going to work around Sue here, who's doing great compressions. Get it up to the defibrillator, which will give the heart.
Analyzing heart
Sue,
rhythm.
stop CPR. We're
Do
going to
not
analyze the
touch
heart.
the patient. Shock advised.
Okay, I'm going to shock.
Stay
So clear.
of
Everybody
patient.
clear.
Deliver shock
I'm
now.
shocking. Shock.
Correctly shock delivered.
Okay, resume CPR.
Oh,
Needed
so wait.
to begin
Oh,
CPR.
oh,
Okay,
Mr.
so-
Jones. Oh.
You doing okay, Mr.
Here,
Jones?
let's go ahead. Let's check the blood pressure. See how he's doing here. So blood pressure is about 84/48.
Okay.
So we're probably going to need some fluids, and we'll see how he does with that.
Okay, pull some fluids. and get
Okay.
that going. Okay.
So you may have noticed, if you've taken a CPR class before, you know those little boxes that you turn the machine on and the voices talk to you and tell you what to do? Our machines have a built-in AED, and that's the mode that we train all of our non-critical care areas to use. So again, Van, you want to shut it off and turn it back on?
Okay.
Analyzing heart rhythm.
So it's
Do
going
not
to tell
touch
you what
the
it's
patient.
doing.
Shock advised. Stay clear of patient. Deliver shock now.
Okay, it's telling me to shock.
the
I'm
orange
clearing
button
everybody
now.
so I don't hurt anybody, and I'm going to shock.
Shock delivered.
Okay.
So you may be used to something like this in your class. It's a little separate device, but it has the on button.
Adult patient. If the patient is a child, press the child button. Remove clothing from the patient's chest. Open packet and apply pads onto patient's bare skin.
So this is just like what we have built into our AEDs. So just the fact that if you've taken a CPR class and you've practiced with the AED trainer, you are on the right course to helping someone recover from a possible cardiac event.
Thank you so much to everyone at Legacy for walking us through all of that. How much practice do students get with these types of simulations?
That is a great question, and I'm going to say never enough. And the reason I say that is it is an event that happens so rarely, luckily, unless you work in a high acuity area like your critical care, your emergency room, your ORs, those types of places. They see these types of events much more frequently. But if you're on like a medical surgical unit, you may not see codes very often, which only stresses the importance of more and more practice. Because when we don't put our hands on emergency equipment very often, and then all of a sudden we need to use it, we don't always have the confidence to move forward and do it very efficiently. And so we do what we call just-in-time training. And it's kind of like what Van and I just did. We pull in 2 staff members at a time on a unit. One will do CPR, the other will run and get the code card, make the call for help, and hook up and deliver a shock. And then we have them flip roles, and then the other person will do CPR, and the other person will run and go get the code card and defibrillate the patient. And even if you can just do that once every couple months, it's that motor memory of a skill that you're just doing repetitively. Studies have shown that CPR even every 2 years is not adequate. We need to practice those skills much more often. And this allows us at the bedside to pull a staff member in. They don't have to come in on a day off. They don't have to, wedge out a block of time. We literally can do it at the bedside, and it takes about 15 minutes for 2 people. And in COVID time, we've actually added a little twist to that, and we cover important information, including PPE, because this may not mean much to you, but it's what we live and breathe every day, is that defibrillation, CPR, and when we're bagging our patients, those are all generating aerosol procedures. And so there's risk of higher exposure. And so we do teach them, the staff, what is the appropriate gear they should be wearing, the goggles, the right masks, the gowns, those types of things. Great question.
The simulation that you just ran us through, how often would a nurse or someone in the healthcare profession encounter that?
Well, I would say for most, not very many. If they saw one a year, that would probably be more than most. However, Kristen and I both have critical care backgrounds. Van has an OR background. So those are all very high risk areas. And especially when you add in that we used to do a lot of open heart surgery. So that just means that the patient is at higher risk for developing an issue where they might be in a coding situation. So, I think all of us can say that we've had a lot of exposures to the real thing, which stresses even more the importance of practicing, because you can walk in every day and be working with different people. And our code teams are designated. They're specific people that when they hear a code, they respond. And so even though the people may change every day depending on their shift, the role that they do does not change. There's always a defibrillation person. There's always a medication person. There's always a CPR person. So that when they show up, they know exactly what they're supposed to do.